Good morning, everybody. Now, NEETs have started this program called Mobile for Mother a couple of years ago. Now we are in a scale-up mode. We are scaling it in 2 districts and 3 blocks with 100% coverage. Our application is, I will skip few slides and later come back to that, because the most of our focus is how this program can be really, because we are talking about the tracking of data, but how this data tracking can help improving, how the action plans are made, how the actions are taken, how the changes are taking place, and what are the indicators that we are tracking. We'll start from there, so that I think we'll be able to generate more interest on it. So we are tracking basically 31 child survival dashboard report. These are the indicators which are supposed to be monitored by NRHM. And with this 31 child survival dashboard report, we are also tracking 16 indicators which again the NRHM wants to track on maternal and newborn health care. So except this adolescent, the plus adolescent which has now added, which we are not completely tracking under this system. So pregnancy, childbirth, postnatal, maternal, newborn, and pre-pregnancy and reproductive age. So this entire life cycle approach based dashboard report, which is NRHM seeking for, we are generating that report from this mobile application. Now I'll go like how we are doing it. This is one of our donor based in Netherlands who are supporting financially to do it. And we are getting a technical support from DEF. And currently we are implementing in 3 blocks, 2 blocks in Deoghar district and 1 block in Pakur district. NEETs works in health, livelihood, and child protection issues. Simavi is basically work on ARSH, WAS, and mother and child programs, so that's why they are interested in our program and supporting us. DF you already know, so DF, we approached DF for application development, etc. So they supported us technically to develop the application. What motivated us to start this program? We started conducting maternal and newborn death audits, and we found there's deaths which can be avoidable, and through a conventional way, we worked since last 3-4 years on maternal and newborn healthcare, but we see that there are no much changes coming up. So we thought of going for some innovation. So that point of time, we approached Dimagi to support us, and we did with the support of Dimagi, we did a piloting, and we learned that how really we can make an impact, because the pilot which we've done in approximately 20,000 population base, it gave a very good results in terms of change in behavior and practices by pregnant women. So it was limited to ANC care during that pilot. Now the product that we have designed is completely covering the entire up to maternal health monitoring system and newborn health care. So our objective is to basically create impact on maternal mortality and newborn mortality. So we started this piloting 2011, and we did a lot of research on it. And finally, we developed a protocol. We selected control block. We did the baseline. So we have enough preparation before we started this final scale-up mode. So we have entire data of these 3 blocks that we are working, and we have selected 2 control blocks. Why 2 control blocks? Because NEETs is also working on a maternal and newborn health in these 3 blocks. So one of the, among the control block, we selected one block where we are not doing a mobile application, but doing a maternal health program. And we selected another block where we are not doing neither mobile application nor the maternal health program, because we want to see actually which program is making an impact. So, so that preparation has been done. And then this is, as you know, that this is a multimedia based software, runs on mobile application. Interpersonal communication is one of the, in the design, it generates a lot of question answers. So we have provided also a kind of a question, frequently asked questions manual to the ASA workers, so that interpersonal communication also takes place. Monitoring of services received by pregnant women during ANCPNC, monitoring of behavior change of pregnant women, reaching unreached pregnant women, even on the home delivery cases where the family insists of home delivery because of various reasons. We also monitor that. And these all are done through the ASA workers' home visit. Regarding one of the, lot of discussion was going on that whether the real data ASA workers is putting, or they are doing some manipulation sitting their home. So we have developed, though this is a GPRS based technology, and even that point of time, if the network is not there, it saves the information, and when the network gets, the data goes to the server. But we have developed, we have put 2 supervisors per block. The job of this supervisor is to do a sample case check. So suppose there are 400 villages and say 1300 families home visits to be tracked. So we just make 6, 7, 8 or 10 sample home visits, and ASA workers are aware of it. The sample home visits are made to see whether the home visits are made by the ASA workers or not. And telling you, till date, we have not found a single case which are manipulated by ASA workers. We also did some from our office itself, some kind of a manipulation in data. Then we found that data which comes to the server, from the timing, etc., it shows that there's something wrong into it. Because when you do a natural interview, the timing, etc., which takes, the ASA worker need to be trained herself to do that manipulation if they're doing a false reporting. So through that triangulation, we found that, and from our field visit, we found that there's no manipulation going on. So as I said, the data transfer goes to the website, then customized reports can be viewed. And this reporting system that we talked about, that we shown you the indicators list and the dashboard reporting. So this software from the website is able to generate that data. And then how this data can really help creating an impact at community level. So what we started doing is attending roster meeting. Now, because we can generate a data, ASA-wise data also we can generate. We can generate ANM-wise data, that means ANM catchment area, sub-center-wise data. We can generate CSC level data. So we started generating ANM level data, so that ANM, and we attended attending the roster meeting of ANM. So through a color mark, red, yellow, and green, it's very clearly seen which are the area that ANM need to make an attention. So this is a very simplified color-coded information which is provided, and through also a graphical representation that what are the issues that ASA workers or the ANM or the MOIC has to take. So that is very important at that level to take a decision. Few samples of like total number of, so these are the kind of questions and picture that mobile has. महिला का पंजीकरण संख्या क्या है? This is always asked in every questions to confirm that this is the particular woman that we are talking about. सहायता इस महिला को कितनी बार मिली है? गर्भावस्था की अवधि क्या है? क्या अपनी गर्भावस्था का पंजीकरण एएनएम तथा स्थानीय स्वास्थ्य केंद्र में किए हैं? So this gives whether the woman is attending the ANM, ANC, PNC, etc. So these are the kind of questions that we have, and the relevant picture comes into the mobile. So this mobile is used by ASA worker, as I said. So the data that it basically generates the total number of pregnant women registered for ANC, number of pregnant women registered within first trimester. So then from this data we can generate also cohort, like all pregnant women of first trimester, all pregnant women of a second trimester, so that we can see that what kind of a particularly facilitation action or referral services etc. is required for that particular trimester group, how many women will be coming, which is the expected date of delivery. So the CSC can prepare themselves how many women will be coming for delivery during which period. So whether that much facility is available there in CSC or what alternatives can be done. All these kind of discussions now started based on this data and information at CSC level. So for example, the total number of NSV on conventional vasectomy conducted at public facility, PSC, CST, or whatever level, state-owned public institutions, number of NSB or conventional vasectomy conducted at private facilities. So these are the data also is generated through this application. So first trimester registration to ANC registration, that is the data is generated. Pregnant women receive 3 ANC checkups to total ANC registration. Though we have a system of tracking in our software is up to 4 ANC, but the government here want to monitor up to 3 ANC. So we have used that what government want to monitor. Pregnant women given 100 IFA, total ANC registration. So when it is here, it is given, but we have found through our data which is generated that is given but not used. So then the interaction takes place. So that there we have put those frequently asked questions, that why a Folifer tablets to be taken by women. So when we have seen that when that discussion goes on, the intake of Folifer tablets goes up. These are the few we selected because we as we were recently improvising on the software and technology with the support of DEF. But during that period when this was getting ready, it delayed a little due to various reasons. So we started using the same thing with a 6 panchayat levels. Somewhere we also use some offline information and data to come up that what kind of behavioral change is taking place. So we can say that on this 6 panchayat level, the increase of ANC registration from 24 to 62% increased. Increase in birth preparedness, 18% to 82% families started on a birth preparation. Increase in taking nutritious food during ANC, increased 22% to 79%. Increase in colostrum feeding, 16% to 72%. Increase in exclusive breastfeeding, 41% to 92%. Increase in safe abortion practices, 32% to 100%. I must say here that we also educate people on safe abortion. What is safe abortion? What are the safe abortion facilities are available? Why you should not go for a RMP for abortion? So we have created few volunteers on that, and women are given sessions on safe abortion and male engagement in safe abortion and family planning. So those program goes on simultaneously other than this mobile application. So increase in cases, increase in awareness of RTI stay, where the women accept the referral services, go for treatment. So 13% to 83%. Increase in institutional delivery, 24% to 70%. So this shows that the changes is taking place, and these changes which we are showing you is approximately 6 months data only. So now we have this project for next 3 years to run, And now we have complete software in place, and government has accepted to take this as a under their monitoring system. So when we approached government, they clearly told that if your application clearly supports our dashboard indicators monitoring, then we'll accept it. So we have where we do not have resources for having a providing a mobile to ASHA workers and do. So we taken another 2 blocks in Sahibganj district where we call it a case management. So same application we have put into a diary, and we did that sampling with 20 sub-centers. Now government, district government has adopted that for the entire districts, and we are providing technical support to do that. So it is completely offline, but with the similar design through a case management process so Sahibganj district is doing. That means this is a higher possibility that if we government is accepting it, so there is a possibility that Sahibganj also go for a mobile application, because it will reduce a lot of data generation, entry, etc., and real-time data can be monitored. So what we see that can be used to educate pregnant women regardless of their educational status. Breaking down barriers helps SAHIA working with women with various disabilities, and real-time data collection that can be shared with government officials and other stakeholders. Challenges: SAHIAs taking time about the use of application. Even SAHIAs were unable to texting, because we don't have a text services here, but still they have to put some data during question answer. So those were then the children are playing with the mobiles, and sometimes they corrupt the software. So those are the kind of some issues that we found, and we try to communicate, have monthly meetings with them to solve those kind of issues. So since this is additional mobile, we have allowed ASHA workers, SAHIA in Jharkhand they called, to use this mobile at their own mobile. So our input per annum is only 50 rupees charge. So since they are using it, and that much is actually money is required for a GPRS transfer of data. Rest, to keep the mobile alive, they are since they are using it as a normal mobile, so they recharge it, so it goes on. So we don't have any burden on providing money for recharge every time. As I already mentioned, that this for advocacy we have planned this, like control. We are putting also a research associate for that, so that our intention is to come up with a complete research paper in Lancet, so that it can be accepted at all level, and actually we can show what kind of outcome that we are looking at. So we have completely prepared for that, and we have engaged people for this research and continuous feedback. Thank you.
ASHA worker, and the ASHA worker talks to the woman. And it is during this question answer session that you are hoping that there would be some interpersonal communication, some exchange of information. Am I right in understanding?
Yes.
That's basically it. So the entire training of the ASHA worker is on exactly what is the element.
One is the application of mobile, because we are providing that mobile to ASHA workers.
Correct.
This question answer and voice message, voice and the picture application that mobile has.
Yeah.
So ASHA workers ask one, and these questions are designed like knowledge and practices. So first question is related to the knowledge that pregnant woman has and the practices she does. Okay. So that input based on this conversation ASHA worker put here. So that inputs are very easy, 1, 2, 3, 1, 2, 3, like that. So that data gets generated. So that shows that what information and knowledge that a pregnant woman has, what is the practices of pregnant woman has. So in this process we found this, since these are all close-ended questions, there are times For example, if they know whether you know about certain symptoms we talk about related to STI, RTI. If say yes or no, so the option is here only yes and no. But we actually don't know how much they know and what they do. So then we have trained ASA workers in such critical questions, what kind of communication you will be doing other than this input.
So the trigger in that entire thing is the
Trigger,
picture
yeah,
and the voice of asking that question,
right.
and then it's up to the ASHA worker to take it from there,
Right.
to add more and
Right.
to give her that. So
Right.
the training is on two aspects. One is
application,
what is the application,
use of application,
and two, the content, the knowledge, the information that she needs in order to enhance the knowledge or the practice that's happening.
So through some FGD and in-depth interviews, we identified those critical areas that where actually interaction should take place. So based on that, we prepared these frequently asked questions and document on that.
I throw it open to others. Sanjay?
First of all, thank you very much for the presentation, and I like the slide on challenges, because many a times when we talk about good practices, with every good practices there are challenges, and we know for sure that if you want ASHAs to use mobile even for keying in, so there is this alphabet and there are numbers, and we know that all our ASHAs are not.
We lost 2 mobiles also. That also happened. 2 mobile missing, lost.
So that
so
is
those kind of small things will always happen.
So point one, if you briefly talk about your experiences about training kind of illiterate ASHAs in terms of using mobile to key in data and some of the information, how long it takes, what are the challenges, and how frequently you need to get back to them. Because if we are thinking in similar lines, we'll also have to think about how do we go about trainings for our ASHA. That is point one. Point two is, I have seen this and I like this because there is this inquisitiveness involved, because the question and answers is asked by the mobile and not by the ASHA.
Yeah.
So she puts a mobile and there is a voice which says, okay, आप breastfeeding करते हैं क्या? तो थोड़ा inquisitiveness आता है. And the third thing, which I don't know Sama is here or not, and this is where, here we are talking about integration. So if nahi aata hai, if she is not practicing breastfeeding, then you have a small clip on breastfeeding saying what are the advantages of breastfeeding. So you are doing the counseling then and there. So you cover all the aspects of it.
Exactly.
So hopefully if we organize a similar kind of thing in Madhya Pradesh, we will call you on board to gain from your experiences. And before you leave, if you could give us all those thing in pen drive, wherein what are the questionnaires, what are the back-end element of this entire software. Because the health department is really keen to move forward here. They have already 77,000 mobiles and all. So we will be working on something which is useful. So all those work which has been done, you also and the other presenter, the one who presented from Kerala, with RFP and all, so that would be very helpful.
Yeah. 6 to 7 days illiterate ASA workers require to get conversant with the mobile. And we have also found even the children, even if have not, of their families have not seen a mobile, but they gets very well acquainted, and sometimes the ASA workers, if they forgot something, they approach their children to train. So that is also happening. So we all found out from the training sessions from themselves. So we found it's useful. No, in any type of disabilities in the form of the. No, it's in the population. So suppose a pregnant woman who can't talk, right? But since but she can hear and she can see the picture. So that also can be tracked. There are many times that disability in the sense, it's not the physical disability, disability in the sense of some contents which ASA workers is taking here. So ASA workers herself, because they have their 7 module based training, most of the things they forgot if they don't practice. So they sometimes they themselves don't know what is, for example, what is STI and what are the symptoms of STI. So then they have a ready reckoner here. They can immediately refer and they need not go and ask somebody else.
The questions are here. There is a there is a small question. Once you developed this system, if there is a revision, so how does that revised module get into the Asha's mobile? Or have you faced this kind of a situation? And in the first place, it was through a web-based system that it got installed?
No, no. It is, we directly apply that into mobile.
Through the SD card or through USBs? Okay.
Yeah.
Okay.
Yeah.
It's a heavy. Very long time. So for any revision also probably that would be the
revisions. When the revisions are required from the field, when we work, we found there are certain questions that to revise, certain pictures which, because we did a field testing all that, no? So we came back to DF that these are the changes we need. So they revise the software, then we re-download that. So revision is always possible, updating is always possible. Yeah, actually, unfortunately, I'm not carrying the mobile. So, but these are the questions like, आपका पूरा नाम क्या है, आपके पति का नाम क्या है, आपके गांव का नाम क्या है. These are basically registration. This is first visit. आपके पंचायत का नाम क्या है, आपके ब्लॉक का नाम क्या है, आपके जिला का नाम क्या है, आपका मोबाइल का नंबर क्या है, आपका गर्भावस्था की अवधि क्या है, मोबाइल का नंबर क्या है. मैं अगर मोबाइल नहीं है तो बोलेगा नहीं है, तो it gets generated. आपका उम्र क्या है. So it will be an unique ID for the pregnant woman, including Sahaya ID, supposed to be automatically generated after end of the data input process and will display on the mobile screen. Sahaya needs to note down that no and will use it for future interaction with that woman till PNC. So this registration is done, and this registration will be taken till the last home visit. Mobile will ask these questions. Voice already incorporated into this. Just yes, no, or whatever name they have to write. So texting. Yeah, that is one time. Once that is done, then it goes up to. That is No, we have trained all them. Even illiterate woman now is able to do it. Yeah, we took 6-7 days time. Now they are able to do it. Yeah.
You never know which woman is going to be literate or illiterate being faced by the Asha.
True.
It cannot be static.
Yeah.
Today we have oriented or trained some women, maybe a number of days only. Tomorrow there will be another 10 or 20 women. Only after tomorrow.
No, this has to be done by ASA workers, not the women.
My concern was that orientation of beneficiary, means pregnant woman, is not a static process. It has to be dynamic only, because this life cycle is on and on. It is on and on for so many thousands of years and will continue. We never know till what time. So this process cannot be taken up at one go only. It has to be continuous process.
Yeah.
So I find there is some problem or difficulty, particularly in terms of the questionnaire. The 9 questions, 1-to-1, it's a sort of rapid fire, and that illiterate woman of that forest or rural background has to face what is your name, name of village, name of panchayat, name of block. I tell you, even urban people, they cannot tell.
No, we have never faced that problem. And because the ASA workers already knows,
no,
even
Asha must be knowing.
Yeah, so
that
ASA worker is from that village.
Yeah.
So there are certain information, even she knows the name of the village. She is because from the same village, name of the district. And here, for example, since that particular mobile is working in a particular catchment area, because the Sahaya worker is that village only.
Agreed.
So this data is only Sahaya worker has to put the name of the woman and nothing else. This is already there. Yeah.
So many of the questions are already answered there. You
Already answered there, because when we give the training to the ASA workers, and that ASA workers.
No, It is
All
not for the
ASHA workers' data is already put. ASHA worker means which is the village, same village ASHA worker will be going. So village, block, district already is there in her mobile. Only she has to put the name of the woman.
My suggestion is that we have a problem in MP. Like we are having Sarpanch Pati, we are having Asha as Sarpanch Bahu, and she is most of the time illiterate. And so now the urban health mission, we have got urban Ashas, and they are 12th pass. So for a start, we can start this your app in urban area very well.
Great. Thanks. I'm glad we're looking for solutions. Any one burning question, and then we'll move to the next presentation because we are behind schedule. One. Suggestion to this or suggestion? We'll take it bilaterally. One question.
Okay, so just one question on this one. There seems to be a lot of, I see that, and that's a little bit of a discomfort, that there is over-dependence on the technology. That, you know, when we're interacting with a certain segment of people, like the question which was asked earlier, it's a similar kind of a question, that a mobile speaking to a person, right, when especially there is a person sitting there with the mobile, what is the particular need for the mobile to speak to a person?
That's the most interesting part, and why that is the USP of the success of this program. The same ASHA workers, when we did kind of a FGD and in-depth interviews of ASHA workers, that you are already trained on these modules. You are working since last more than 3-4 years. That why suddenly that it started working and earlier it was not working. We already had our home visits. The things came up, जब हम बोलते हैं वो सुनती नहीं है, मोबाइल बोलता है तो सुनता है. This is all about attitude. And जब मोबाइल बोलता है तो this is something which I must listen because this is something truth. ये तो आशा वर्कर मेरे घर की है, क्या जानती है? That makes a lot of difference, and that has made a difference. And when we, because as it seems like here a lot of questions and ASHA worker has to put lot of literacy etc. is absolutely not required except the putting the name. So putting the name, as I said, that they have learned that much in 6-7 days training that they can put the input of the name. Rest of the information already there in her mobile. So this is required. Why? Because HMSI data required this much of data, the registration. So that's why it's already available in the data. It goes to the GPRS, to the website, and it is for one time only. Rest are yes or no, means push the number button 1 or 2. So it is absolutely easy for the ASHA workers also to put the input of the data.
Excuse me. Yeah. My simple question is that you said that there is a need of unique number generation processes there in the software, and we have MCTS also, and there also we have a unique ID for mother. So isn't it confusing for ASHA?
Same unique ID we are using because the government has to use the same data.
That's
When you want to register the name, they have to type. There is another option, we can also even register through voice. So that option can be given. That's possible.
Yeah.
If that is given, I feel everything will be taken care.
Yeah.
Even the FAQs, as when we have to just see it, it is better we can even pronounce it. And it can say yes, and it will be answered yes, then it can register.
Yes.
So if it is even if they are not computer savvy or even mobile savvy, or they don't know how to write, they can communicate through voice.
Yeah.
That would be the best option.
Possible. Yeah. Thank you.